So, hello, my name is Emilio Torres, and we are going to speak about how to improve corneal cross-linking for progressive forms of keratoconus. So the first thing to have in mind is how prevalent keratoconus is. So this is a chart, an image that shows all the prevalence studies that were published so far. And in the year of 2018, we show in a population in Saudi Arabia that it is much more frequent than in most areas of the planet, but also much more frequent than we used to report. So here reaching up to 5% of this population. So cross-linking came up in 1998 with the first studies. Then in 2003 came the first clinical results. And nowadays it is already the global standard of care. In 2019 we had already more than 2,000 Medline entries using corneal cross-linking. So when we think about corneal cross-linking, we think about the clinical response. So the first protocol that was developed was the Dresden protocol. So here I will show you now first the Dresden protocol results, because that is what we have for long-term data. And as well as many disease and treatments in medicine, also here the clinical response to cross-linking follows this Gaussian pattern, so that the majority of the cases there is a flattening in around 2.7 diopters after 1 year. However, there are some cases which we see a massive flattening. They are not so frequent, but also some cases in which we see failure. Normally what we see is a flattening that starts a year or more after cross-linking and then afterwards stabilizes. And this paper which we presented in ESCRS 2019, we show our results from the Zurich group from IROC and ELSA, showing the 10 years follow-up data from the Zurich patients, and we saw that even after 10 years the keratometry still were reduced. And by the Kmax, what we observed after 10 years was still a flattening of 1.3 diopters, which was fantastic. So as I said, the typical flattening is around 2 diopters after a year, and here is what you see. But also on the right image, you see some cases in which the flattening is so intense. So there is a massive remodeling effect, and here we see as well in the right below image another patient, another differential map showing this huge flattening. Interesting is that this flattening usually comes with haze due to the massive remodeling, but interestingly, those patients not often suffer from low or decreased visual acuity. You can see here after cross-linking all of those patients improved vision. So this flattening with haze might be in some cases not so bad as we could think, because the optics of those patients are very different. But there are those cases they have haze, and there are cases that we see after cross-linking that still have haze. So haze is very controversial in cross-linking because theoretically it could only be mediated by activated keratocites, and during cross-linking or after cross-linking we kill keratocites. And so about haze, there are two interesting points. Here you see a cornea 3 months after cross-linking was performed, and it is clear that there is a haze, and this is demonstrated by the densitometry, so the differential map on the right below image. And in this case, we should ask ourselves if haze really is causing the alteration of the corneal surface, and this has a direct impact with our technology that we use. So are the technology that we are using good enough for differentiating and to measure these surfaces even with haze? So that's a question that we've been looking at, and here you see the difference between OCT and Scheimpflug. So here we see how OCT equipment has an advantage in assessing the surface in such cases with corneal opacity. Of course, most of the corneal haze after cross-linking is mild, but in cases which is really intense, this makes can make a big difference. A second point about haze is that we curiously identify that, contrary to what one would intuitively think, mitomycin C or mitomycin C, MMC, in some situations can increase the haze. And this is what we have observed in combination with cross-linking. So we believe that the mitomycin apoptotic effect on those keratocytes population together with cross-linking would result in a major cell dropout in the treated area, and this would be probably the reason why we, even using mitomycin C, after cross-linking there is increases in haze, and this was measured with software. So another point is about biomechanics. So as I commented, when cross-linking was divided, two parameters were taken into account, and they were UVA light and also riboflavin. However, another recently a factor which now we know that is essential was at that time not known, and this element was the oxygen. So now we know that oxygen limits the cross-linking reactions, and oxygen is essential. So in the right column you observe the stiffening effect in corneas which were in which cross-linking was performed without the use of oxygen, so in a chamber with helium as the image shows. And when the oxygen was not available, there was no cross-linking. And so oxygen is essential, and understanding this is very important because it explains several alternative techniques that are emerging. For example, the accelerated cross-linking or the epi-on cross-linking or even pulsed cross-linking, but also other techniques. So as I said, the more we speed the procedure, the less biomechanical effect we have, and here shows exactly this. So the Dresden protocol, in which are represented here in the blue column, has still the highest stiffening effect, but as we decrease or as we accelerated or as we decrease the time of the surgery, the effect also decreases. The biomechanical stiffening effect also decreases. And these could also be observed also not only in the stiffening effect, but we saw some gene transcription changes of the extracellular matrix differently, and these changes were differently when the procedure were either normal, Dresden protocol, or accelerated. So even in the gen transcription, there is a difference. So in summary, so far the articles show that accelerating to up to 10 minutes, the biomechanical effect should be clinically satisfactory, so good. But after that, so if we do so fast, for example, 5 minutes, the clinical stabilizing effect does not seem to be as we would desire. And that's exactly what we shown here now with this paper recently published, showing that 9 milliwatt for 10 minutes was clinically good. So the patients had a stabilization of cross-linking, or with cross-linking had a stabilization of keratoconus up to 5 years. So this should bring now the 9 milliwatts for 10 minutes also as one of our gold standard procedures for most of the cases at least. Another point is cross-linking that keeps the epithelium, so what we call epithelium on cross-linking. And here there is a lack of good results nowadays, showing that most of the cases here showing the laboratory results with unsatisfactory results. So the stiffening effect is still not so good in the lab, and also clinical results showing no stabilization of keratometry readings, or failures reaching up to 30% of the cases that use it transepithelial or epi-on cross-linking. That has already been shown in one of our papers, in which we try to modulate the time and the energy making the transepithelial, or trying to make it more effective, and actually increasing the time in transepithelial cross-linking, we could reach a better effect. But still, as you see here in the blue, last blue on the right column, this increasing effect with transepithelial cross-linking was still much less effective than any other epi-off protocols, which are shown in the green columns. So the understanding of oxygen is essential, because it brings all this information together and make us understand all those protocols in a very logical form. So another point I would like to speak about is about thin corneas. So this has been a limitation for many years, and corneas like these with pachymetry reaching, in this case, for example, 350 microns, until now there were limited options to treating cross-linking. The same here in a cornea with a corneal thickness of 260 micra and a good vision with contact lenses. So what could we offer to this patient in order to avoid keratoconus progression? So the first technique in 2009 was the hypoosmolar riboflavin, and then came afterwards other techniques also trying to supply this lack of treatment for thin corneas. So the first one, as I said, was using hypoosmolar riboflavin, and this uses actually this osmolarity gradient. So it creates an osmotic gradient and bring the cornea in a thicker pachymetry or the thickness is increased. And at first we thought about, on the first years, it was thought that the stiffening effect was not so good, but recent studies such as this one from 2019 show that it works, and it works similar as it would work for a Dresden protocol or a standard protocol. The big issue here is that by using a hypoosmolar riboflavin alone, we have this variance of pachymetry increase, and this was not predictable. So this is a limitation of this technique. Then some years later, a new technique was offered or was proposed, in which a contact lens would be used to increase the corneal thickness. And as you can imagine, we already saw, as we put some material over the surface of the cornea, the oxygen diffusion would be limited, and therefore that's the reason why we observed a reduced stiffening effect in corneas using protocol with contact lens assisted corneal cross-linking. You see here in the blue lines on the left image, but also another study from 2019, both using stress strain measurements and digestion, showing that contact lens assisted was 30% less efficient than standard cross-linking, and the reason again it was the oxygen. So that's why our group and Farhad Hafez especially came with this idea, in which instead of modifying the riboflavin concentration of any protocol or even the thickness, we would make the adjustment for the cornea using only the adjustment in the UVA intensity. And the reason for this would be to simplify the method so that all the ophthalmologists, even with the oldest machine, could use this technology or this protocol. So this was published now in 2021, and basically what we do, instead of adjusting the cornea to the protocol using hypoosmolaric riboflavin only, or even contact lenses assisted cross-linking, instead of doing this, we would adapt.
Tienes una cita presencial con tu preparación académica, con los profesionales de la salud visual de América Latina, con los negocios.
Asegura tu cupo en franjafedopto2021.com inscripciones.
Enfrentando eficazmente la era digital.
The protocol to the cornea. So thinner corneas would receive less energy, and that's already our results showing a year of follow-up in patients with cornea ranging from 2014 to less than 400 micra. And after the epithelial removal done, the riboflavin was dropped, and we used this published table to adapt the energy to each cornea. And for our surprise, after 1 year, here you show now the results, for our surprise, most of the patients stayed stable. So there was no significant differences in refraction, and also the vision stayed stable. And again, for our surprise, the keratometry, or the maximum keratometry, decreased by 2 diopters, which would be very similar with what we see in standard cross-linking. So a fantastic results that show only a failure rate of up to 9%, so a very good failure rate. And here you see images from corneas that now can be cross-linking, and you see the demarcation line on the upper image showing corneas as thin as 220 micra that were cross-linked with sub-400 protocol. And here's some images showing those results, a standard flattening after our protocol. Another approach that has recently been published from our group is also using this protocol for treating keratoglobus. So before there was no available treatment for those corneas using cross-linking, and here we use it cross-linking, as you see, and 2 years after cross-linking, still in even those very advanced keratoglobus, still we could find a stabilization of the case, and this was published now as well in 2021. So going to the end of our presentation and what we think would be the future. So as I said, there are many factors that are used in cross-linking, and probably a combination of small changes of many factors would be the way to go from now on. So far we have either used change in the light or change or in fluence or in the time. Now we understand better than ever how those parameters play separately. So combining those factors should allow us to have more effective treatments, even with transepithelial or epi-on cross-linking in the future. So this is another paper submitted this year in which we show even accelerating cross-linking that we could reach a better stiffening effect, and this was due to the combination of those factors. A last point that I would like to show, and that's also a news, is that cross-linking now can also be used at this slit lamp, not only for treating progressive forms of keratoconus, but also for treating infectious keratitis. So this is what we call PAC cross-linking. So using the cross-linking at the slit lamp, from now on, we would allow patients to be treated even in very remote areas where operating room is not available. And here you see some video showing how this device would fit in a standard office. So you see it's very easy, and the treatment can be done in the office. So as a final message is, after 10 years of follow-up, the epi-off Dresden protocol, that was the standard protocol, the first one. So the epi-off Dresden protocol was able to achieve long-term stabilization in most of the cases. A novelty here, so news, is that mitomycin C after cross-linking increases stromal haze, and this for many can be some counterintuitive. Now, with individualized cross-linking using sub-400 protocol, we are able to treating ultra-thin corneas as thin as 220 microns for examples, and accelerated or combination of many factors, as I said, can be used for providing similar biomechanical stiffening effect, but in a way that the surgery would be faster, bringing many advantages for both surgeon and the patients. So with these messages, I would like to thank you for your attention.